Okay, welcome everyone. My name is Russ Derry. I'm the Pediatric Epilepsy Program Manager at Mott Children's Hospital, and it is Epilepsy Awareness Month. So we're really pleased that you're able to join us today for this really important topic on seizure emergencies. This is one of our epilepsy expert webinars, and we're thrilled to have with us today Dr. Giulia Benedetti, who's a pediatric epileptologist and neurocritical care specialist at Mott Children's Hospital. Just a few housekeeping issues. If you could stay muted during the presentation, that would be great. If you do have any questions and you want to put them in the chat, you can feel free to do so at any time. Dr. Benedetti may be able to address those if she sees them, or we can address them at the end of the presentation. We'll have about 10 to 15 minutes at the end also for questions. So if you have any questions, we can open it up for discussion at that point. But with that, Dr. Benedetti, go ahead and get started. Thanks so much.
Thank you. And thank you so much for inviting me to give this talk. As Russ said, I am an epileptologist. I trained here at University of Michigan for residency in epilepsy. So I've worked with a lot of the people that your children probably see in the hospital. And then I came back here in 2022 to form the neurocritical care program. And so most of my work now is in the ICU, and I see a lot of seizures and seizure emergencies there. And so I was hoping to use this opportunity to talk to you guys as the parents of children with seizures about what seizure emergencies might look like for your child, and what happens at home in the emergency room, and then if they have to come into the hospital, what that might look like and why we do what we do. I very much welcome questions and discussions, and I think I have it set up where I will see the chat come up if you have a question, and I very much want this to be an open dialogue. If anything, if you have any burning questions while I'm talking, please feel free to put that in the chat. So I don't have any disclosures. The only funding that I receive is through the Pediatric Epilepsy Research Foundation for work on a type of EEG we call quantitative EEG in the ICU, and that hasn't influenced this talk in any way. And then I get some salary support for the neonatal seizure registry. The things that I wanted to cover today, that parents, when I ask them, what is the thing that you fear most about your child having seizures? The one that comes up often is, could this seizure cause permanent brain damage? And so that's where we get into talking about prolonged seizures and the effect on the brain. And then the other one is, could this seizure kill my child? Could it result in death? And that's kind of the biggest emergency, of course, that we all fear. And I want to talk about that very openly. The risk is very, very low, but it's something that I think as neurologists, we should have open conversations with our parents about. And that's usually what's on people's minds. This is not the same as having epilepsy, but when I was a toddler, I had a febrile seizure, and my aunt, who was pretty young at the time, was babysitting me, and her first thought, she thought I was dying. When parents witness a big seizure, that's often the first thought. It's such a scary thing, and I don't need to be telling you guys this, but that's it's often the fear that comes up most. So again, this is just kind of framing why we're talking about it today. Um, okay, so diving into prolonged seizures, we'll talk about that first, and this is something we call status epilepticus. Some of you may have heard of this. Some of your kids may have had status epilepticus. It happens to about 30,000 children per year in the US. And for children who have epilepsy, it's about 10 to 20% of them will have a prolonged seizure. But the vast majority of seizures do stop on their own before they hit that 5-minute mark where we now define status epilepticus. But when they don't stop on their own, that's when we think about giving extra medicines for help. Um, we know that some children are at higher risk for developing status epilepticus. One risk factor, if they've had a prior prolonged seizure, if their epilepsy started at a young age, if their epilepsy is something we call symptomatic epilepsy, meaning they're having seizures because they've had something that triggered their epilepsy, like a stroke or a bacterial infection in the brain, like meningitis, that can increase your risk of having status epilepticus. And then we know that as we learn more and more about genetic epilepsies, there are certain genetic epilepsies that are more commonly associated with going into prolonged seizures that need rescue medicines to get the child out of it. And so it's important as we think about the cause of your child's epilepsy to know if that's an epilepsy that is commonly associated with status epilepticus. Um, and this is kind of dry, but we in the epilepsy world we change the name of things often, like the names of different epilepsies, and we also change the definitions of things as time evolves, as we learn more about these conditions. And status epilepticus is one that has changed, and I think the change has been for a very good reason. And I was really happy with this change that came about. So when I was a trainee, uh, back in the early 2010s, we I was taught that status epilepticus is if a seizure goes on more than 30 minutes. And then in 2015, the International League Against Epilepsy, which I love that name, it sounds like a superhero group, but they changed the definition of status epilepticus and they called it an operational definition of status epilepticus. And the goal was they wanted to change how we, as the treating physicians and teams for your kid, um, treat status epilepticus and how soon we react to it. And I think this was a really positive change. So let me see if I can get the little pointer going. There we go. So we now have different definitions for when we call something status epilepticus, and it is actually different depending on the type of seizure that your child has. And so for kind of the most classic seizure we think of, which is a tonic-clonic convulsive seizure where your child might stiffen and jerk. Um, for that type of seizure, we call it time point one, or the first time point of status epilepticus, once they hit 5 minutes. And if any of you have a rescue medicine for your child, that's usually when we will say, that's the time point at which you need to start treating. The broad definition of this first column of time point one is that it's the time point at which the normal mechanisms in the brain that would kind of shut down a seizure on its own have failed, and the seizure is unlikely to stop without help from a medicine. And so that's that time point where they've labeled it as this is the time that we, as the physicians or as the caregiver, that's when we need to act and give them a medicine, because it doesn't seem like they'll be able to come out of it on their own. And so for those bigger seizures that take up a lot of energy, that's 5 minutes. Then there's a other type of seizure called a focal seizure with impaired awareness. So that might be like your child looks off to one side and is unresponsive to you, or has jerking on just one side and not the full body and is unresponsive. Um, but those seizures, we define that first time point at which we would start treating at 10 minutes. And so some of you might have seizure action plans that are different than that typical give a rescue medicine at 5 minutes, and that could be because your child has a focal seizure. Um, and that's not always the case. Sometimes we will just keep it set at 5 minutes just to keep things clear. So you're not trying to decide, is this a generalized seizure? Is it a focal seizure? But sometimes we will lengthen that time period because these may stop on their own before 10 minutes and may not need treatment. And then if any of your children have absence seizures, they're a staring type of seizures. They used to be called petit mal seizures, where the child just stops what they're doing. They have a behavioral arrest. Sometimes you'll see eyelid fluttering. Usually those are very short seizures, but we they've labeled this as time point one to consider treatment at 10 to 15 minutes of a continuous absence seizure. But they put in the paper a caveat saying we really don't know what that time point is, because those type of seizures don't seem to cause we don't have evidence that it causes any kind of permanent injury. And so we don't know exactly how long those seizures can go on. Sometimes we'll have kids who have those type of seizures for hours at a time, and they're confused, but they're still talking and things like that. And then there's no permanent consequences of that. So this one is a little bit of an unknown. Um, and then time point two is what we've defined as the time point at which we really need to get, if the seizure's still going on, get more and more aggressive about stopping the seizure, because we worry that that could be a time point at which there is some permanent injury. Um, so for a big full body convulsion, and I'll talk a little bit more about this on the next few slides, we suspect that that time point might be at 30 minutes of a continuous seizure with full body jerking. But where we got that number is from an animal study, and I don't know how well that applies to human children, but this is the time point at which you'll see us getting more and more aggressive with medicines to try and stop the seizure. For these focal seizures that aren't the full body convulsion, they said they estimate probably something more than 60 minutes, but again, that's an area where we really don't know the answer, and it's very rare that I see permanent injury with something like this. So let's talk a little bit about this 30-minute mark, because I think it gets um, parents might get told about this and be really scared when they see their child seizing for a long time, and then the first thought is this going to cause permanent brain injury? And this was actually from a study in 1973 that we haven't repeated in any way, that used adolescent baboon monkeys or primates. And they induced seizures in them. And these were pretty severe convulsive seizures. They and they looked at if any of the prolonged seizures caused permanent brain injury. And what they actually found when you look at the study itself in detail is that the cellular injury typically occurred in those who had been seizing 82 to almost 300 minutes. So that's not that 30-minute mark. Um, and the and it was usually the baboons who had other complications like low blood pressure, their blood sugar got low, their oxygen got low, they got fevers during it. And so it, the ones who were well supported through these prolonged seizures um, didn't have these signs of brain injury. So a lot of what we do in an emergency situation is not just trying to stop the seizure, but support your child's body through it too, and focus on making sure their blood pressure is okay, that their blood sugar is okay, that their temperature is coming down, and things like that. And so um, I think you'll see this 30-minute risk of brain injury, but I just want you to be aware that the evidence that that's based on is quite old, and I think there were a lot of caveats to how this can translate to actual human children. So then one other caveat for if you're for how we define status epilepticus, and this is we've talked about kind of when you're looking at your child, how long are they having a seizure for? The other way we look at seizures is through an EEG, as I'm sure you're all familiar with, and we have an EEG definition of seizures, and so we still will use some of the uh, clinical signs, like the when you can see them if they're on EEG and they're jerking. It's still, if they're jerking for 5 minutes, that's status epilepticus. If they have a focal seizure for 10 minutes, that's status epilepticus. But sometimes children can be seizing and not be able to show us that. And if that happens and we see it only on the EEG, if they're seizing for 10 minutes in a row, similar to the focal seizure that you could see, we call that status epilepticus. And then this is one that we are shifting more as a community to treating more aggressively for these EEG only seizures without any clinical manifestation, with no jerking or anything like that, is if they have more than 12 minutes of seizure in any 1 hour period that we're monitoring, which 12 divided by 60 minutes is 20%. So we call that a 20% seizure burden in an hour. And this was based on a study that looked at kids who came in with seizures to an ICU. So these were critically ill children. Um, and they found that for the children who had seizures that exceeded 12 minutes in an hour, even if they were kind of clustering, um, that could be associated with a decline in how they were compared to how they came into the hospital. And so we used to say that it was 50% of an hour, so you had to have 30 minutes of total seizure time. We've dropped that down to 20% or 12 minutes total. So this just means we have now been getting more aggressive with our treatment of EEG seizures, um, because we want to prevent any kind of decline after your child recovers. So if you're ever in the hospital, and I hope this doesn't happen, but if you're ever in the hospital and your child's on EEG monitoring and we're talking about seizure burden, this is where that comes from. And it's all just kind of pushing people to treat more. This was a figure from an adult review of status epilepticus, and this was more just to point out the blue boxes are showing things that can happen during prolonged convulsive seizures and why it is hard on the body, like your muscles get really worn out, so they're pointing out the muscles. It can cause your heart rate to go up, it can cause your heart rate to go down, things like that. But this is just to point out more that we are supporting the whole body in status epilepticus, and that's where our team is really helpful, like our ER team, our ICU team, for making sure that we're supporting your child's whole body during status while we are working very hard to stop the seizures. And so the best way that we can treat status epilepticus, prevent any long-term consequences, which again is really rare, is to have a seizure action plan. And so that's it includes equipping you guys as the parents with rescue medicine if your child has had a history of having a long seizure. So you have something at home. It includes having our EMS teams with medications that they can give to your child en route to the hospital. And then our ERs being also equipped and having medicines in the ER, not just on the 10th floor pharmacy that we have to wait on, but having medicines at the ready that we can give if they go past that 5-minute mark. So we call this a status epilepticus protocol here. And what we found is that when hospitals enact a status epilepticus protocol, which might be something written out like this that all providers have access to, it also often includes an order set to make just ordering the medicines and all the care that's needed really easy. That alone, having this plan, can reduce seizure time by 50%. So just having a plan really equips us in being able to help. So as I mentioned, there's this while we're waiting for that first 5 minutes, which probably feels like forever, that's kind of the stabilization phase where we make sure your child's safe. If it's happening in the hospital, that's usually where they'll be thinking about checking their blood sugar or getting vital signs, IV access if they're going to need it, that kind of thing. So that's a really important part in supporting your child through this. And then the first two steps to any seizure action plan are usually 2 benzodiazepines. So those are medicines that act by decreasing overexcitable neuronal firing. They're really good at what they do, and they're really good early in status epilepticus. And we like to make sure that it's two adequately dosed benzodiazepines, not like quarter doses or half doses like we kind of see with status. We really want to make sure we have you set up with a good dose. So this is just, I think, maybe one of two of the molecular slides that I'm going to show. But for those who are interested in kind of what happens in status epilepticus, we've kind of put the different neurons that are communicating with each other and where the medicines are acting. And so when we're talking about the benzodiazepines, that is this group here. So diazepam, we also call that diastat, lorazepam or Ativan, midazolam or Versed. This is where they're acting, and these medicines are really good at slowing down seizures. As seizures go on and on and on, those receptors where the drug is binding get internalized into the cell. So those benzodiazepines, those medications can be less effective after the seizure goes on for a while. And that's where we need to think about using other medications like Keppra or levetiracetam, valproic acid, that kind of thing. And so that's part of why we do those rescue meds that we send you home with. We do it early and we do a good dose and we see if we can stop it in its tracks. And if we can't, then we need to move on to other mechanisms. And this is kind of the molecular reason why. So you may be familiar with some of these. There's a couple different options for how we can give our first line benzodiazepines. There's the rectal diastat, which comes preloaded with the dose, which is nice that you don't have to think about drawing up any kind of a dose. And that goes up your child's bottom. And what I usually will tell families is they're laying on their sides because they're having a seizure. You inject the medicine, and I have to hold the cheeks together so that because sometimes pushing a medicine in will trigger a response to kind of push it out, and so hold their cheeks together so it can get absorbed, and then you wait and see if it is effective, and it is very quickly absorbed through that mucosa, so it's a good route. But for older kids, especially school age kids, they often don't want to have rectal medicine or have their classmates know that that's their rescue medicine or anything like that. So now we have several nasal formulations, which is nicer for our older kids. We used to more often before we had Nasalam and Valtoco. We still have this option to draw up the individualized dose of midazolam and then spray it up the nose during a seizure. Some parents really like this. It's an effective way to give the medicine, but it can also be hard in the moment to have to draw up a medicine. Whereas now we have Valtoco, which is diazepam, or Nasalam, which are preloaded, and you don't have to think about the dose at all. And so um, some some kids require a gastrostomy tube for various reasons, and so G-tube can be another way that we can get medicines in, but that's similar to our oral meds. It's absorbed slowly through the gut, so it's not ideal, but some kids who have refractory seizures respond really well to certain medicines that can be given through the G-tube, so some people might have that on their seizure action plan. Um, and then there is intramuscular and then intravenous options. We were part of a study several years ago looking at when the EMTs come and if they administer a dose intramuscularly versus getting an IV and injecting it through the IV, which was more effective. And it was kind of a washout. It took longer to get the IV medicine in because you had to get an IV in. But the time to seizure cessation between those two groups wasn't any different. We don't really have a preference between the two. It's just kind of whatever we can do, whatever the EMTs can do fastest. Okay, so we get our benzodiazepines in, and that might be part of your medicine you have at home. It might be something that EMTs have. And then if you've given the 2 doses of the medicine and the seizure's still going on, that's when we need to switch to a different mechanism because at the molecular level, things are starting to change at that point. And this is where we get to some of our IV medicines that you may or may not be familiar with. But the options that we have for giving a medicine through an IV in the setting of status epilepticus are fosphenytoin or phenytoin. Dilantin is another name for that. Levetiracetam or Keppra, valproic acid, or Depakote, Depakine, phenobarbital, and lacosamide or Vimpat. These are our main options here at Mott. And when we think about things that are associated with how well a child is going to recover from status epilepticus and risk for um, status epilepticus causing problems, there are kind of three main things we've figured out. So one is if they're less than a year of age, there's a higher risk that the recovery from status epilepticus will be harder. The cause of the seizure. So again, if there was something like a stroke that's causing the seizure in the status, there's a risk that there might be some deficits after that. And then the time to getting the medicines in. And this one is the one that we can influence. And that's really our job. We can't change the age or the cause of the seizure, but we can influence how we react to the seizure. And so that's our role as the physicians, and in equipping you guys at home too. So we talked about the first line medicines like the Diastat and Valtoco, they become less effective after the seizure has been going on for more than 30 minutes. So then we need to move on after that to these second line meds. And I mentioned this a little bit earlier that just having a pathway in the hospital where you tell people what are the next steps, when is the time you need to give it, that can reduce the time to getting that second line medicine by more than 50%, and it reduces the total seizure time just by implementing these pathways. So we need to equip our physicians and providers in the ER to all be ready to treat on a timeline. And we talked about that. So let's talk about our second line meds. Um, this is the other trial slide I was going to show. This was the ESET trial, or the Established Status Epilepticus Treatment Trial. The results came out in 2020. We were a site for this, both on the adult side and the pediatric side. And what this study was looking at was treating status epilepticus with one of three of the IV medicines that we have. And seeing how effective they were in stopping seizures. And they looked in children and they looked in adults. And so the medicines they used were the fosphenytoin, valproic acid, and levetiracetam. Um, and basically, they were all equivalent in terms of whether or not they stopped the seizures. So it was almost 50-50 for each of the medicines. So this was trying to figure out, is one better than the other? And the answer was no, they're all equally effective and have about a 50% chance of stopping status epilepticus. Um, when we look just at the children's arm, um, there was a difference in the fosphenytoin or dilantin. um, there was a higher rate of the child needing to be intubated or have a breathing tube put in and be put on a ventilator with that medicine, but not with the other two. So for that reason, in a status epilepticus situation, I will typically go with levetiracetam because there are fewer side effects with that, and they're less likely to need breathing support or blood pressure support or anything like that. And similarly, actually, most of these did not cause a blood pressure issue, and it was just 3% and 4% in the other groups. But again, levetiracetam or Keppra really didn't have that side effect at all. So if they're all kind of 50-50 and this is the safest one, this is why we often will go with levetiracetam in the emergency room. Okay, so after that, if your child is still seizing, that's when we need to move on to some of our infusions. And so this is where they might be on a Versed or midazolam infusion. That's usually our first line. Once we get to that point, we will, if it's not already on, we will typically start an EEG because for two reasons. One is that all these medicines, as we treat the seizures, sometimes something happens called electroclinical dissociation, which just means the seizure might look like it stops, like the jerking stops, but if you have them on EEG, you can see the seizure still going on the EEG. So there was a dissociation between the clinical component of jerking and what's actually happening still in your child's brain. And so we need the EEG on to know if they're still having seizures. This isn't the case if your child gets the rescue medicines and they wake up perfectly and you can tell they're not seizing. Maybe they're a little sleepy, but they're starting to come back. They're fussy. They're recognizing you. And that case, you don't need an EEG, but if the seizure seems to have stopped and they're not waking up and we're not getting very good responsiveness, then I need the EEG on to know if they're still seizing or not. And then the second reason to have the EEG on, we typically, once we get to this point of starting a drip or an infusion, I am titrating the infusion dose to stopping the seizure. And so I really need the EEG to tell me when we've definitely stopped the seizures. So this is a scenario where I tell my fellows and residents that you get the phone number of the person reading the EEG, and it is close communication. And I want you start the drip, and then 15 minutes later, I want to know if it was effective or if they're still seizing. And if it's not, then we give another dose of the medicine and we go up on the drip. And this is a very close conversation happening between the EEG reader and the treating team, because we want to do everything we can to get those seizures stopped. And then if we can't control the seizures with this infusion, we can go on to other infusion types. And these all have their own kind of advantages and disadvantages, but they are effective medicines. So that. So in our seizure kind of timeline where we start early with the benzodiazepines, we give the good doses, see if we can stop seizures on their own. Then we move on to our second line of seizures are still going on. And then this is where we get to if we need infusions and some of the things that we can try. Okay. So the take home points from this section is that I think by far the best defense against status epilepticus is just being prepared. And so much of that is our job to prepare you guys for if there's ever a prolonged seizure in your home. If your child needs a rescue medicine, making sure it's up to date, that it's at a good dose, that we're checking weight-based dosing and it's growing with the child. And so having a good rescue medicine at home, having a written seizure action plan that you can have, that you go over with your epileptologist so you know when to give it, you can tell the school when to give it. Having our EMS teams wonderfully prepared, which they are, and then in the hospital, having a status epilepticus pathway and having all the providers who are on the front line knowing what to do next and having several steps ahead to be ready. Um, we Our seizure pathway focuses on what are those molecular changes that happen, what do we know is most effective at which point in the seizure, and I think that will improve our chances of success in stopping the seizures. And then I really want the take home to be that permanent brain injury is exceptionally rare, and a lot of the times where we do see any kind of injury on an MRI, or if we see some deficits after they recover, there's often something else that was going on, like having low blood sugar or having a high temperature or something like that, where we are also doing everything we can to support the body through the seizure too. And so there's a lot that we can do to help prevent that as well. Okay, so this is our mental palate cleanser. This is a picture from Bay Bainbridge State Park in Washington. My mom grew up just around here, and I've been going there since I was a child. And it was 2 years ago that I learned that it was actually named after a physician named Temple Fay, who worked at University of Washington, and he was one of the first pioneers of using hypothermia for treatment of neurologic diseases. So we now use it in our babies who have hypoxic ischemic injury. There is some talk of using it in refractory status epilepticus that doesn't stop and things like that. And so I love this beach, and I love that there is a connection to neurology with it. So before we move on to the next section, I just want to talk about kind of one, to see if anyone had questions on the status epilepticus question or status epilepticus section. Anything that you want to ask about before we talk about other emergencies. Okay, so the next section, as I said, was, oh, there's something in the chat. Um, Oh, yeah. Why was the ketogenic diet listed? So, um, let me go back. I'll show you. So, as we get into more seizures that are harder and harder to treat and aren't stopping with our typical medicines, um, we start to think outside the box. And two of the ways we think outside the box is one is why is this seizure happening and why is it going on and on and on and on, and that's where sometimes the answer is maybe there's an infection or maybe there's an inflammatory process, and we'll sometimes use immune modulating things like steroids to help with that. um, but we also know that the ketogenic diet is a really powerful anti-seizure tool too. Um, we don't entirely know the full mechanism of the ketogenic diet and how it works, but if we're dealing with refractory status epilepticus that has gone on past the midazolam infusion and you've tried a second anesthetic infusion and you're still having problems, the ketogenic diet can be a really effective treatment. Um, and so it's rare, but at least several times a year, well, yeah, maybe a couple times a year, we will kind of crash kids onto the ketogenic diet in the ICU to try and stop their seizures. And sometimes that can be one of the most effective things to be able to get them off of the infusions. Um, but our dietitians, I don't know if any of you have met them, but they are fantastic and they are always willing to work with us day or night, weekends, um, to if we say that we think it'll be helpful for a child in the ICU. We've done that before. Yeah, okay. So a nurse friend suggested looking into pharmacogenetic testing for seizure drugs. Um, I think this is probably the future, one of the futures of epilepsy. And we have a fantastic neurogenetics team here with a lot of close relationships with our basic science labs. Um, as of right now, I know Louis Dang, one of our physician scientists, spoke in the webinar series, but as of right now, I don't know that we have uh, uh, the resources to do that kind of pharmacogenetic testing here in our labs. Russ, has anything come up that you know about that?
Yeah, we have what we call our Genetic Therapeutics Action Committee.
Mm-hmm.
And so we are looking at individual cases to try and
Yes.
find opportunities to do this.
Yeah.
But it's in the very, very early stages, and we're not yet to the point where this can be something we can offer on a broad scale. But
Yeah.
it's definitely an exciting future.
Yeah. Um, and so that might be looking at an individual patient's own genetics and metabolism of drugs and things like that. We also kind of do that in a less scientific way, with checking like drug levels. Like some of my patients are just really fast metabolizers, and I don't know why, and they require very, very high levels or very, very high doses of medications to get a therapeutic level. And that probably has something to do with their own pharmacogenetics that we just don't know yet. Um, and then the other area where we definitely apply this is if your child has a known genetic epilepsy, especially some of the channelopathies like SCN1A, SCN2A, KCNQ2, those kind of channelopathy epilepsies, we are learning more and more about those and which drugs work best for those patients. And so while that's not individually testing how they're metabolizing how their own body is metabolizing the drugs, we will target our drug therapies to what we know of their genetic condition. Yeah. Okay. So the other thing that parents, when I ask them what is their biggest fear for their child who has seizures, and then they 9 out of 10 times they will answer, I fear that they will die from their seizure. And so I wanted to take the last part of this talk to talk about death in epilepsy. Normally, I am having this conversation one-on-one with a patient's family that I know very well, that we've just spent the last hour together. I can ask you questions, you can ask me questions. I can read your body language and things like that. So if this is a conversation you've already had with your epileptologist, or you haven't had it with your epileptologist and you would like to, and you don't want to listen to it over Zoom, feel free to hop off. I will not be insulted at all. But I also know that when we ask parents, they've often already read about death in epilepsy on the internet, and they probably have questions and want to talk about it, and they want to hear about it from their child's doctor. Um, the vast majority, more than 90%, say they want to talk about it. There, one area where we don't know, there was some difference between what parents wanted and what they didn't, was whether or not they wanted their child in the room, but they do want to be the ones to decide if their child is going to be in the room to talk about it. So um, we have just learned in talking to parents over and over again that, like, you guys want to have open, frank conversations about this. So um, there are, the main take-home point that I want to emphasize is that death in epilepsy is very, very rare, but it does happen, which is why we have to talk about it. Um, and it is not always due to SUDEP, or sudden unexpected death in a person with epilepsy. It can be from other causes too. So it could be from an accident that happens because of the seizure, like if someone is driving and has a seizure and they get into a car crash. It could be related to the underlying cause of their epilepsy, meaning some epilepsies come with other neurologic or heart or organ conditions, and it might be that genetic cause that caused the epilepsy is also the cause of their demise. Very, very rarely, it can be from the epilepsy treatments themselves, from a serious adverse event or a serious side effect. Some of our medications can cause liver failure, and while rare, that's a possibility. Some can cause a very serious rash. So again, that's rare, but it's something to be aware of. And then SUDEP, as I mentioned, or status epilepticus, those are two epilepsy-related causes, but again, very, very rare. Um, this this was a combined study looking at um, the reasons for death in children who have epilepsy. And this first panel is showing you 4 different studies that looked at it. And the white bar is epilepsy-related deaths. The black bar is non-epilepsy related deaths, and then the gray is uncertain. So the vast majority are not related to the epilepsy itself. And that's one of the take-home points that I want to emphasize, that the death due to epilepsy is by far it's the least common cause of death in a child with epilepsy. But when you do hone in on these ones due to epilepsy, SUDEP is the most common cause. That's what this one in red is kind of showing you. These are the deaths due to epilepsy-related reasons, related to a side effect from the drug or an accident that happened during a seizure or something like that. So because that is the more common cause of death in a child with epilepsy, I want to focus in on that, because I think being equipped with what the risk is and how to mitigate that risk is the most important thing that we can do as physicians, and you guys as parents too. So SUDEP is defined as a sudden, unexpected, witnessed or unwitnessed, non-traumatic, non-drowning death in a patient with epilepsy, with or without evidence of having a seizure at the time, and not due to having had status epilepticus. Um, and so there's a lot that there's some that we know about SUDEP and the cause of SUDEP, but there's still a lot that we don't know. We we have some information from trying to pool information about patients with SUDEP who have had SUDEP, there is a North American registry that is trying to learn more and more about why this happens, because one of the important things is that we just need to know more about it so that we can combat it and prevent it. The things that we know in terms of um, what might be the cause of it. One is that it most often occurs at night, and the patient is usually found face down. Um, we, in some cases where we have recorded SUDEP, like in an epilepsy monitoring unit, we've tried to gather information from that. And as you can imagine, those cases are very, very rare, but there are a few reported. And sometimes we see that it was preceded by a pause in breathing, a long pause in breathing. Sometimes there's an abnormal heart rhythm. And one of the leading theories is that this lower part of the brain, the brainstem, has a lot of control of your breathing and your heart rhythms and your reaction to things going on in your body, and how you kind of titrate your heart rate, your breathing to what your body's doing. And if that gets affected at the end of the seizure, that's one of the theories as to why this might happen to people who have epilepsy. But we don't have a way of recording from that area, so that's really theoretical. But that's one of the leading guesses that we have. Um, we also know kind of the type of patient who is most at risk, and that's usually it's more often in young adult men who have frequent uncontrolled convulsive seizures and who have seizures at night and who live alone. Those tend to be some of the bigger risk factors, and so because we know uncontrolled convulsions are a risk, you will find that that is often when your doctors get more and more aggressive with treating your child's seizures, because we want to lower that risk as much as possible. Um, and I think knowing about that risk is a way of empowering us and empowering you guys. For adults with epilepsy, SUDEP can happen in 1 in 1,000. It is less common in children. It's more about 1 in every 4,500 child, but that's still a number that we need to change. Um, in thinking about what do we do, knowing that we don't know, we don't fully understand what causes SUDEP, but we know which children are at higher risk for it. What can we do as your doctors, and what can you guys do as parents, right? So frequent convulsions, we know that's a risk factor, having these frequent tonic-clonic shaking seizures, especially if they're happening at night. So um, we will do everything we can, working with you guys and working with medicines, balancing side effects to try and get those seizures under control. Um, the and again, that might be where you see your doctors getting more and more um, uh, uh, aggressive with their treatment. If you know seizure triggers for your child, like sleep deprivation, doing what you can to avoid those kind of things. Stress can be another trigger for a lot of children, and it's hard to avoid stress in life. It's hard to avoid infections, but doing what we can to avoid seizure triggers, making sure you have regular appointments if your child has recurrent seizures, making sure you're working with your epileptologist to get those under control. Um, we think about things like epilepsy surgery if the seizures really aren't stopping. So we move beyond medicine sometimes if we really need to get this under control. And then having an effective seizure action plan. We know that certain genetic epilepsies are more associated with SUDEP than others. And so um, if your child has refractory epilepsy and has a known cause, we probably have information about those risks for your child. And so knowing what the type of epilepsy your child has can be helpful too. And we know that patients who live alone, which isn't a big issue for our population that we're talking about, but patients who live alone in adulthood are at higher risk. And so CPR training is something that I usually recommend for any of my parents who have had a child with a convulsive seizure, just that they get that training. And then there's a lot of interest in the different devices. So there's epilepsy watches, and that's what I'll spend the last few minutes talking about. There's seizure detection devices, and then there's nocturnal supervision devices, and then things like a baby monitor too. So I just wanted to talk a little bit about those. And the important caveat that you will hear if you go to any of the websites about SUDEP or any of these websites about the monitoring devices is that while many of them are FDA approved, they've been shown that it's safe and fine to use. Um, they have never been shown to actually reduce the incidence of SUDEP. But I think a lot of that is because SUDEP is so rare that it'll be hard to ever be able to show that these devices make a difference, but that doesn't mean they don't make a difference. And the peace of mind they can provide to a family can be invaluable. The downside to these is depending on what device you're looking at, there can be a lot of false alarms. And then if you are waking up multiple times a night, you are not getting good sleep. Your child probably isn't getting good sleep. And if these aren't seizures that are waking you up and it's just a restless child, that can actually lead to more problems for the whole family. And sleep deprivation, we know, is not good for seizures either. So it's kind of a balance. And I typically tell families, especially if their child has frequent nighttime convulsions, that um, that I think it's a very reasonable thing to do. And I will always work with you guys to like write a prescription to see if we can get it covered by insurance. That doesn't always happen, but we will do what we can. Some of these have grant programs where they can help with funding. So in terms of the different monitors, there are movement detection monitors that can try and detect abnormal rhythmic movements and alert you. There's the Embrace epilepsy watch, and that works best for jerking seizures. It has an accelerometer that is pretty good at detecting big jerking seizures, but not as good at detecting other types of seizures. Um, the Inspire app can pair with an Apple Watch or a Samsung Watch and has some technology for detecting seizures as well. Um, this is called the Night Watch, and that, as you can see, it actually goes on the arm, but that's another device. And when they've actually looked at it on a large scale, they've detected about 90% of motor seizures and have a very low false alarm rate. Um, so this is one that we've been hearing more about. There's the Owlet is one that's mentioned on one of the SUDEP resource websites. This measures pulse oximeter, heart rate, but it is not designed as a seizure detector. So keep in mind that that's not what it was designed for, and it's not good at detecting seizures, but it can detect low oxygen levels and changes in heart rate. And then often, honestly, what I and other people spoken, other epileptologists with a lot of experience in this, a simple baby monitor, you guys are usually so in tune to your children, I think, that even you would hear abnormal rhythmic noises on a monitor. And sometimes this is the best way to kind of work towards being comfortable with them being able to sleep, but that way you know you have ears on them at least, and then the video can come up too. Um, so we still need more understanding, more research in this area. We are partnering with parents and with other epileptologists and device makers and things like that to just figure out what can we do to reduce that number of SUDEP per year. And then these, I hope the QR codes work, but these are different resources that you can have. There's a lot available out there. So the Epilepsy Foundation has some facts about SUDEP and frequently asked questions. There's the SUDEP Action Network. The PAME is the Partners Against Mortality and Epilepsy, and they pair with the Danny Did Foundation. And they have a lot of resources on their website too. And then the SUDEP Aware website is another great resource for families. So I think a lot of you, if you've gotten our seizure packet, we have links to, or information about the Epilepsy Foundation. There's a lot of really helpful information there too. But there's again, we're all working together to try and do what we can to reduce the risk. Okay, I went longer than I thought I would. I apologize, but I'm happy to stay on if there are any questions. You are welcome to put it in the chat or unmute or whatever. And I encourage you all, this is it's it's a hard conversation to talk with our families about SUDEP, but it's something that we are all very, very passionate about. And if this is not something you've talked about with your epileptologist, absolutely ask questions. There's on those websites, there's a list of questions you might think about asking your provider and things like that. So again, we are here to help.
Okay, any questions?
Okay. My son is autistic and nonverbal, but I'm wondering if he can sense when he has a seizure coming, when a seizure is coming. Have you noticed that you can, that something about him changes before it's coming on? No, no. Um, so even in our nonverbal children, I think if there is, we sometimes we'll call it a seizure aura, or some of the very early stages of a seizure can cause a kid to feel funny. But usually they will be able to, even if they're nonverbal, can tell us in some way. And so it may be that they really don't feel anything. Especially if you're not noticing a change in them, because I think you guys know your kids so well, more than anyone. And if you're not noticing a change right before the seizure, it's probable that that's the same experience for your child. That it's just coming on really quickly, and they're not experiencing anything scary beforehand. Ah, so uh, in terms of like a trained dog to help detect seizures, um, it I it is a resource that is out there. One of the challenges is that it is really expensive to train a seizure dog, and sometimes the costs can be prohibitive. Russ, do you know, do we have any resources about that?
Yeah, I can provide information, and I can actually send some information to you, Jessica, if you'd like.
Okay.
And but yeah, the cost can be $20,000 or more to train one. And the other issue is that there's no guarantee that they will develop the ability to detect seizures before they occur. Some may develop that ability, but there's no a trainer cannot say that yes, we can guarantee that this dog is going to be able to do that for you. So in more cases, it's they're going to be able to respond to a seizure in a way that you train them, but not necessarily detect a seizure beforehand. But for many people, just being having a dog being able to alert them if a seizure has started, or do some simple things to respond to the seizure can be very helpful. But again, the cost there's also often very long waiting periods to get one as well.
And
Okay.
sometimes if you have a family dog that is really intelligent and trainable, that I think that can be an option, but still the training has is a process.
No, that's a really good point. There are some people who've just sort of their pet dog has kind of developed these
Yeah.
abilities on their own and with a little nudging, basically. So yeah. All right. Well, looks like people are wrapping up here. So thank you so much, Dr. Benedetti,
Of
for a really
course.
thorough and informative presentation. And again, this is recorded, so if anyone wants to go back and listen to this, it will be uploaded to our YouTube channel shortly. And again, thank you all for participating